Afternoon, everybody. Today is July 8th, 2025. Welcome to the. Oh, I see your message, Rudy. Some fellows are having issues logging on. More are expected to come. Okay. I'll wait for one more minute and then I'll hit it. Okay. Thank you, Rudy, for speaking up. Or Rowdy. Rowdy. Well, this is the introduction, so I should be okay. So we'll consider now the start point. Alrighty. Uh, Good afternoon, everybody. Welcome to SEVA VentRounds. Today is July 8th, 2025. And today we're going to present a case in which the question is NAVA discordance. And it's more about taking a look at the waveforms and trying to understand where they come from. So this helps put things into context. There's no endorsement of any mode, ventilator, or manufacturer. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic. There's my conflicts of interest as well as Rob's. Rob, are you on the line?
Here, can you hear me?
Yes, perfectly. Perfect. Remember, this is recorded, so just keep your session muted, your microphone muted, and I may call you or Rob may call on you to comment, but if you want to unmute at some point and make a comment, please go ahead or put it on the chat function of WebEx. Both work well for us, and we are monitoring both. And there's CME and CRC for all of these events. For our respiratory therapy colleagues, just complete the evaluation. So I thought I would start with this one, just to highlight some of the thought processes that we have and that we have to keep in mind. Just recall that whenever we talk about synchrony, the patient is the reference signal. And as the evolution of mechanical ventilation and technology has become more available, although many of these has been available for decades, it now has become more present in our ICUs for utilization. And in no way, or shape, or form we are endorsing this as the way that you need to use for monitoring synchrony, but it's a good example and a thought process of how the signal for breathing is generated and how this becomes the reference. So to start, just remembering that the patient is the reference signal, the signal that we can capture now from the brain, the closest that we can get it currently is from an EMG. And there's different ways to get that EMG, but now the most practical for us and commercially available is to do the electrical activity of the diaphragm. And although this doesn't look like an EMG per se, if you have seen an EMG, it looks like a spindle on its own. This is a simplified or filtered image that was generated, and it's present in the getting ventilators, the servo ventilators. But there, suffice to say that there's other ways that you can get EMGs from the surface muscles to with other types of electrodes, but this is the one commercially available in the NAVA catheters. And as the image starts and the signal starts, there's a rise here, signal by one, in which the baseline activity, electrical activity of the diaphragm starts increasing, and that signals the start of the breath. And then it will continue until it peaks, and then after it reaches the peak, it starts decaying, and then it goes back to baseline. And so that's the electrical activity of the diaphragm. Now, if you're using the electrical activity of the diaphragm to calculate the trigger, there's some thresholds that you can set up for the trigger for the start of the breath. And then for the cycle, the company has set it up at 70% of the peak electrical activity of the diaphragm, and that has to do because that's the way that they and we can talk a little bit more about that, but how the the signal or the peak flow and the cycling was occurring on the signal, and it has to do with some delay on reaching pressure and flow signals. But that's how it occurs, and so that's how they chose it. But the peak is right here, which is marked by number 5. If you then use the other technology that you can use available now on ventilators is to use the esophageal pressure. And the esophageal pressure, that's a catheter. I'm sorry, I didn't show this. So the NAVA catheter goes and captures the diaphragmatic signals through the esophagus through these sensors on a catheter. That's where it lays. And then when you do an esophageal pressure as a surrogate of pleural pressure, there's a catheter with a balloon that is placed on the esophagus and in close proximity to the pleura, and it transmits the changes in pleural pressure. And so you can see how the pleural pressure starts decreasing as the diaphragms go down. And here marked by number 2, you can see how there's a difference between the electrical activity and the pressure change. And then the pressure goes down, and there's a peak where essentially it stops going down, and then it returns back to baseline. And so the breath technically ends up here in 4 or 5. I mean, we put here 4 because it stopped having any change. And so that's the signal obtained from the esophagus, that it's a direct marker of the respiratory muscle activation. And then if you're missing that signal, the next one that you have is the airway pressure or the flow signal. And I put here just the airway pressure, but you certainly can use the flow signal too to use that as a reference because of the changes that it has of the PMOS or the activation of the muscles. And you can see here signaled by number 3 that there's a drop in pressure, and that drop in pressure, then there's the trigger of the breath, or that's where the breath starts essentially. And so that will help you see where the PMOS starts and then where it ends. And you can see that this breath in general, it ended all the way over here. You cannot see the PMOS because there's no flow signal, but you can use those signals. So usually at the bedside, we use the airway signal, so pressure and flow. If you have the esophageal pressure, then you would use the esophageal pressure. And you have the electrical activity of the diaphragm, then you would use the electrical activity of the diaphragm. But suffice to say is that you immediately can realize that if you're using the electrical activity of the diaphragm, you're going to be more sensitive to detecting problems in trigger and cycle. Or if you're using the esophageal pressure, you're also going to be more sensitive. Rob, thoughts?
Yeah, just to point out that the airway pressure waveform is not a NAVA supported pressure waveform. This is a mandatory time cycle breath, and you're indicating that there's a delay cycle at 6 compared to 5 on the EDI. Now the EDI cycles the breath off for a NAVA breath at 70% of peak. That's not something that you can adjust.
That's absolutely correct. And actually, here you also see that concept of neuromechanical uncoupling, just to mention it a little bit. But you can see how the diaphragm, the EMG continues to peak, but the esophageal pressure stopped dropping. And so even though there is activity and the brain is asking for more, and this is a subtle example, but there's more marked examples in which the pressure may not change further based on the electrical activity, and that could be because of neuromuscular weakness or physical limitations of the lung reaching total lung capacity and whatnot. So those things can occur. But this is useful for you to see the neural is the reference signal. If that's absent, then we use the muscle, and then if not, we use the airway. Recognizing that that's not the usual way. The usual way at the bedside is we use the airway signals. So with that said, here's an example, and the goal here is for you to we're going to take a look at this image, and it will help us. There's a fair amount of information going on this image, so we'll dissect it little by little. So to start, if any of our the audience wants to talk about or put in what's the tag for this mode. And while you type that, I'll read a comment that Ariel said very clearly, that it's clear NAVA captures only the electrical activity of the diaphragm, not the other respiratory muscles. So, and this is important because there's patients that may have the diaphragm paralysis or abnormalities on the diaphragm. One of them may be paralyzed, and you may not be capturing the signal, or they may have activation of other respiratory muscles in out of phase with the diaphragm muscle. So thank you for that, Ariel. So everybody has put here PC-CSVr, and just for the sake of making this clear, I mean, we're saying that the mode is pressure control, and we understand that the majority of us, when we think about pressure control, the ventilators usually control pressure by creating a square waveform. So when the breath starts and then it ends, they're trying to create a square waveform. But in this case, that's not what you see. You see this waveform that it's pretty irregular in shape. These two waveforms that are over here. So I'm going to put a 1 and a 2 for those two large breaths, and then later we'll talk about these little ones. But these two big ones, you can see that they're not a square, and that is because what's ruling this, it's the electrical activity. So the signal from the electrical activity of the diaphragm, the ventilator is giving pressure proportional to that, and so you can see that this image of the electromyogram or electrical activity of the diaphragm is being mimicked there. So you can see this shelf that occurred here, or this gradual increase with a shelf up here occurring in both of these breaths. Rob, comments?
No, just to reinforce what you said, that the servo targeting makes inspiratory pressure waveform look similar to the EDI waveform.
And then the CSV just means that it is a patient-determined signal that is triggering the breath and cycling it. And in this case, it's being triggered by the electrical activity of the diaphragm. And if you recall, in this ventilator, the signal that it's triggering changes color. And so you can see down here that it used the electrical activity of the diaphragm. You see a little white. I'm going to amplify it for a second so you can see it a little bit better. You see that little changing white? That tells you that it's being triggered by the electrical activity, sorry. And then the second breath is actually triggered by pressure. So in this ventilator, it uses a first come, first served basis triggering, in which you can set a pressure or flow trigger and the electrical activity of the diaphragm trigger. And whichever happens first is the one that will trigger the ventilator. So this breath was triggered. The first thing that happened was the electrical activity that triggers. In this breath over here, it was the drop in pressure that led to the trigger of the breath following rapidly for that. Rob?
It's just kind of complicated, isn't it?
Yeah, it's one of those, but it's important for you to recognize this, because there's sometimes that you will see breath trigger on one side, and it may make you think that NAVA is not working. It's just one of them is triggering first than the other one. And this speaks to the comment that Ariel mentioned regarding how the muscles, the respiratory muscles, activate. And sometimes the upper chest may activate first, starting to drop the pressure, and then followed by the diaphragm activation. And so, I mean, it's more complex than we're used to, than a lean one follows the other all the time. But when there's disease, there may be these abnormalities. Alrighty. So if you look at because we're controlling pressure during inspiration, what's the load during inspiration? Elastic, resistive, or PMOS? And for that, you look at the flow waveform because we're controlling pressure. So what's happening during inspiration? Elastic, resistive, or PMOS? Yeah, so almost by definition, because you're on PC-CSVr, you should have PMOS as the main load during inspiration. That's what you would expect to see. And just to highlight why we are saying that is if this was pressure control and it was passive, you would expect to see this waveform, an exponential decay. And instead of that, you say a sinusoidal, almost sinusoidal waveform, which is consistent with the normal, what you would expect with flow during normal breathing. Rob?
Yes, that's very clear.
And then during exhalation, what do you see? Is this passive, elastic, resistive, or PMOS? Yeah. So there's a lot of you are recognizing that this is likely to be PMOS. And we say that it's likely to be PMOS because there's again the same image, but in the inverse should be happening here. The exhalation should be passive in patients, and we don't see that passivity. Instead of that, we see that the flow is continuous throughout. And so this makes you think, one, that there's active PMOS because the patient is actively exhaling, and the second, and Raquel, you're absolutely right on this, is that there may be some resistance, resistive load because the patient is actively exhaling, and there seems to be some flow limitation there. So I think that that's not out of the question, and this is where PMOS hides the things, but you would suspect that would be one of the causes because that's how this is looking. Yeah, there you go, Karsten. Good job. Rob?
Yeah, that's great analysis. It's hard to distinguish between those two things. I suppose if you were standing there looking at the patient, you could just put your hand on their abdomen and see what they're doing, right?
Yeah, and this is one of the rules. I mean, of good high quality respiratory care is that when you have one of these patients and they have a discordance, you use not only the sense of sight when looking at the ventilator screen, but the other one, besides looking at the patient, is putting your hand in the chest or the abdomen and listening to the ventilator. I mean, there's a lot that comes from just listening at the air go in and looking at the patient and how that interaction is occurring. And so that can help a fair amount when going through this. Very good. So now let's go into the patient ventilator discordance. And as I said, there's a lot of stuff happening here. And so let's start by the trigger and talk about, is this normal, early, late, false, or failed? And for the sake of I'm gonna let you guys answer, and then we'll come. And I see some Fernando is on fire, and it's already triggering there. Megan is also putting options. Anybody else? Yeah, so I see some support for Fernando, and I would highlight here a couple of items. So you have several items, and I'm gonna highlight these little things over here, and you can see that there's a change in color, which tells that something triggered. Yes. Yeah. So these ones that I have put an arrow on, including this one over here. So I'm gonna go all the way on the top, and I'm gonna, instead of putting 1, 2, 3, I'm gonna put breath A and B, because you can see that there was a change in flow, right? and the flow doesn't reach baseline. But there was a change in pressure, and then over here there's this lonely friend over here, and there's this C, another one here, and then there's this one over here, in which there's again a change in there's a trigger, at least identified by the ventilator. Remember, the ventilator is using this to recognize, to saying there's a patient signal, patient signal, patient signal. But because it's proportional, it will give proportional to the electrical activity of the diaphragm the amount of pressure. And in this case, the NAVA level was set at 0.7. So it will detect a change in millivolts and or microvolts, sorry. Thank you, Vlad, because you corrected me on one of the SEVA courses about the microvolts. So it's the strength, it's very small, and so, but it leads to a change in pressure, and it's not enough to generate flow that crosses the baseline. And you can see that little sucker there. So you can see that A, B, C, and D, all of them are, but however, you can see that some of them didn't. You see this one over here, I'm going to put an asterisk, and this one over here didn't lead to a trigger, and neither did it happen over here. And there's another one here. You see that? So now that you start looking at them, do you see, there's another one here, sorry. Do you see how regular they're happening? Can somebody think what's the cause of these ones there? Haha, yes, Eric. Awesome. It's the heart. So this is a type of false trigger because it led to a trigger on the ventilator. It's probably inconsequential. It didn't cause much change on the volume, but it did cause a volume. You see how it reset the flow on the volume on the ventilator. So the ventilator definitely detected this, and here's another one that it detected a breath. But these are false triggers by the EKG contaminating the signal from the NAVA catheter. So that's EKG contamination of the cardiac of the NAVA signal. And I mean, I didn't know what it was. I actually sent a message to Christer Sinderby, who made actually NAVA, and asked him what is happening here. And that was this is exactly what's happening. So we needed to readjust the NAVA catheter to ensure that we're not getting contaminated. To see that. So this is a really cool item in which you have false triggers because of the electrical activity of the heart contaminating the electrical activity of the diaphragm. And this is relevant because they have put a lot of technology to try to filter these signals. And I mean, technologically, this is really impressive because you can imagine the amount of electrical activity noise that is occurring around the esophagus. There's the diaphragms, but there's also other muscles, and there's the heart. So this signal has to filter those images. But as you now take a look, it becomes really evident that these are cardiac oscillations. I mean, this is one of those is. Yeah, Fernando, well, perhaps not misplaced, but we adjusted it. But yes, you need to take a look at the catheter and adjust it to see if you can get rid of those because they're creating noise on your signal. So that's a false trigger by in NAVA, perhaps of no consequence, perhaps of no consequence, but present, and it can generate enough anxiety on us when we're taking care of these patients. Rob, comments?
I think that's a very good example. It seems to me pretty rare. It doesn't happen very often because the filtering is usually pretty good.
Yep. Yeah, but when it happens, now you know. Now there's one here to show. Um, and then when we look at the other two breaths, the breath number 1 and breath number 2, and we evaluate their triggering based on the NAVA signal, you can see that uh, even though this one was activated by the pressure waveform, they are all in synchrony. So I would say that in terms of how they behaved, uh, both of them seem to be normal. These two that are over here. And then during inspiration, let me ask you, the team, what do you think? Is there assistance, over assistance, or under assistance? In the two breaths that are normal, right? Not the false triggers. So for this, for breath 1 and 2, not for A, B, C, D. Yeah. So Robert Karsten says, Fernando says assistance. So and I think there is definitely I mean there's no over assistance. I would say that's one of the items there, and perhaps there's no under assistance. So Rob, thoughts here?
I'm thinking that because you have an EDI peak, you can say that there's a normal range for EDI peak.
Mm-hmm.
And if it's too low, then that would be over assistance. And if it's too high, it's under assistance. I think that's generally true, but I can't remember off the top of my head what the values are, what the acceptable ranges. But I think a peak of 1.1 is relatively low.
Well, just the EDI that is measured right now is for one of those false triggers.
Okay, there you go.
If you see the scale on the side, some of the peaks were close to 30, some were close to 25. So there's a range of values for the EDI activity. So that's a challenge. So and this has to do with how do we define under and over assistance, right? So there's definitely the ventilator is assisting the patient. The question is this too little or too much? And so yeah, that's exactly what I'm saying, Ariel. How much is the question? Is this too little clinically for the patient or too much? What I do recall about this patient and the reason why the patient ended up in NAVA is this patient, we were doing diaphragm protective ventilation because it was going for a transplant, and we were trying to support as much as we could the effort because the lungs were extremely injured. And so that's correct, Karsten. The range usually they try to put it at 15. And so it was very high, and the patient had even higher than this. But then we were starting the reason why we got this image was because of the false triggers. But yeah, we thought that the patient was being assisted. The work of breathing was better, but still had a very high electrical activity of the diaphragm. I mean, this was a patient with pulmonary fibrosis, actively breathing in and out, very, very, very hard. All righty. And then the cycle. I wanted to talk a little bit about cycle. So just in summary, I don't have a perfect answer for NAVA and assistance and the definition of over and under assistance. I think that these are things that we have to come to terms on how are we going to define this in general from the electrical activity, or is it going to be the tidal volume, or is it going to be other alternate findings of over assistance? Good comments. All right. So in terms of cycle, is this normal, early, or late? Yeah. Yeah. So many of you are reading this. Some here I put a question mark with assistance. Sorry. And here there's a lot of people that are talking about normal by definition. So what I would look here is for features that would tell me that there is uh, early cycle, and I don't see features of early cycle. And what I would look for features of early cycle would be the peak flow and then evidence of inspiratory effort after that. I don't see that right here. You see how the diaphragm has deactivated, and this could happen again, as we said, there could be other muscles activated. The NAVA only shows you one muscle, I mean, the largest and most important, but one of them being activated. And then during inspiration, we don't see, in terms of late, we don't see the flow going to zero before we get to the change. So I would say that this is pretty normal looking in the book, and it correlates with the cycle of criteria that they're using for this, which is 70%. So it doesn't end at the peak; it ends around 70% of the peak inspiratory flow. And then during expiration, we talked about expiratory work that was recognized early by all of you. Yeah, that's a good item. The one of the points that Ariel is putting, was there any limitation on the pressure during and the answer is no. The peak pressure alarm was set much higher than that, Ariel. Thank you. Not in this case. Sometimes you can see these plateaus at the top of the pressure waveform when you set a pressure limit too low, and then the breath will be pressure limited during that part of the breath, just because you set an alarm back down. So in summary, just to put everything in context, this is a servo or proportional mode in which you're going to see that it's ruled by the EMG, and the pressure will mimic the waveform of the EMG. We see evidence of PMOS during inspiration and expiration. We recognize that pulse triggers can occur because of EKG on this type of mode, and that's a contamination that occurs because the filtering is not working well, and that could be causing, that may need you to adjust the catheter location. We talked about assistance, and there's evidence of assistance, but the definition of over assistance and under assistance in this mode in particular are not entirely clear to me, and I don't think that to many, but it's a source for us to investigate more. We talk about the cycle and how these cycles at 70% of predicted, and then we talked that there was evidence of expiratory work and the importance of us at the bedside checking these patients. Rob, any final or any thoughts?
Oh, that's a great summary.
All right. So any questions or comments from the audience? All right. Very good. Excellent, excellent, excellent. So here's the CCF CME, the CRCs for RTs. Please take a picture or scan this, and you'll get that power. Remember to send us your images. There's my email and Rob's. We're happy to talk about this. This is our segment number 94. So keep sending us images, and all our prior episodes are here on the SEVA website. And then just remember to register for the SEVA program, which will occur in September. And we're happy to have you. We're almost out of spots, so please register. Have a great day, and thank you very much for all you do for your patients. Have a great day.